Interventions with a King. Discussion and commentary based on articles from Jack, Cardiovascular Interventions.
I'm David Holmes from Rochester, Minnesota, and I have with me Dr. Freek Verheugt from Amsterdam. The hospital that he's in is Amsterdam. I cannot pronounce, and I'm not even sure that you can pronounce it, Freek.
Yes, it's Onze Lieve Vrouwengasthuis, or OLVG. Perfect. Yes.
It's great to have you here. We're going to talk about an issue that has assumed increasing importance, and that is the issue of bleeding in patients undergoing percutaneous intervention. Can you talk a little bit about the issues? How frequently does it occur? What does it mean?
Yeah, we more and more look now more at bleeding than at efficacy of certain interventions. Bleeding in intervention cardiology depends largely on the indication. In elective PCI, you shouldn't have a lot of bleeding. In acute PCI, in STEMI or non-STEMI, then of course the bleeding is increased because of the co-administration of anticoagulants. And the incidence depends largely on the classification. We have TIMI classification, GUSTO, but in acute PCI it is about 5% of major bleeding needing transfusion or surgery.
And what does that mean from the patient standpoint, the fact that they bleed? Does that have other issues related to it rather than just the need for a blood transfusion?
Yeah, that's a very good point, David. We have seen now in the larger registries and also in the trials that patients who bleed have a much worse one-year outcome than patients who do not bleed. They do not bleed to death on the table. That's very rare, thank God. But it's a marker of comorbidity. And that's, I think, very clear from the studies. It's an independent prognosticator of bad outcome in the months and years after a PCI.
We talk about the difference between access site bleeding and other, for example, GI bleeding. Can you talk a little bit about that? Do they mean different things?
They do. We will publish a paper on that. The doctors, cardiologists at least, look at the access site bleeding. It's important, of course, but the spontaneous bleeds that occur during or after the intervention are even more important for prognosis. We found out in 17,000 patients that patients who bleed not at the access site have a 3 times higher one-year mortality than those who bleed at the access site. So the comorbidity should also be taken care of, like the GI tract, the GU tract, and the blood constituents.
In your 17,000 roughly patient population, when does that occur? You said that non-access site bleeding may occur early as well as late. Give us the temporal profile of that.
The most of the non-access site bleedings occur in hospital.
Really?
Yes, when the patients get the anticoagulants, the antiplatelet drugs they need, many have a significant drop in hematocrit. So the most frequent sites are GI, GU, but also unknown locations because of a significant drop in hemoglobin. And so we cannot localize those, but people who do that have a worse outcome. So they should be scrutinized for other conditions than their acute coronary syndrome.
Does it affect transfusion practice? Are transfusions part of this?
That is a very good point. We need a randomized trial on that, whether we should transfuse or not. Of course, people in shock, they are very low hemoglobin, they need transfusion, but not that many patients drop their hematocrit so much, and they get a transfusion anyway. And we know that transfusion by itself is also an unfavorable prognosticator for outcome. Blood is not very healthy to get, and especially older blood lots are not so good.
So we've talked about the issues, the frequency, the variable classifications, what it means for the patient, and the fact that it depends upon whether it's access site or whether it's not access site.
Yes.
It's been an incredibly important discussion.
It is.
And we appreciate your involvement in the field to help us learn what to do to prevent it.
Yes, but the way to prevent it, maybe for a short last statement about that, I think we need safer drugs, and we need safer exercise, like the radial side is probably better to prevent a lot of bleeding. And I think that people should switch to the radial access.
Perfect. Have a great meeting. Great
Thank
to
you.
see you.
Thank you, David.
Thanks.